Welcome to our panel, PN05, Patient Participation at the Organisational Level in Health Technology Assessment. I'm Anne Single, the chair of the HTAI Patient and Citizens Involvement Interest Group, and I'm also with Patient Voice Initiative in Australia. I'm going to be your moderator for this panel. I join you from the land of the Turrbal and the Yagara, which you may know as Brisbane in Queensland, Australia. So before we begin, I would like to acknowledge the traditional custodians of the land where I live and work and pay my respects to their elders past, present and emerging. Can I also apologise for my voice today? Just a head cold, but I will stop and turn off my microphone if I need to cough. And then I will turn it back on and resume. So I haven't run away, I'm just having a cough. And because of the cold, I'm just going to turn off my video while presenting. In this session, we're going to explore this topic with our four panelists. Just change the slide. Great. Our first is Dr. Hervé Navarrete. Hervé is the Deputy Director of Public Affairs in the patient group AFM Telethon in France, which is dedicated to neuromuscular diseases. Prior to this, he worked for many years with the French HTA body, HAS. Hervé is a member of our PCIG steering committee, and a few years ago, he raised the need to study this topic of patient participation at the organisational level. And it's been my privilege to work with him on this study, which he leads. Daniel Cairns is the Patient Advocacy and Policy Officer for Myeloma UK and a member of the Scottish Medicines Consortium's Public Involvement Network Advisory Group. As part of Myeloma UK's patient advocacy team, he gathers patient insights and evidence to inform all their submissions to the drug approval bodies, advocating for new treatments for myeloma and associated conditions. He is also responsible for their policy and influencing work in the devolved nations. Our third panelist is Dr. Elizabeth Orlean. Elizabeth is Assistant Vice President, Research and Programs at the National Health Council in the USA. In this role, Elizabeth crafts the NHC's annual research and programmatic agenda in service of its mission and leads the NHC's work on value, real-world evidence, and patient engagement. And finally, can I welcome Alice Evans. Alice is the Patient and Public Involvement Officer with one of our newest HTA bodies, Health Technology Wales. She is responsible for providing information support to patients, patient organisations, carers, and members of the public. Before joining Health Technology Wales, Alice worked across National Health Service trusts in Wales, working with patients on grassroots projects to improve patient services. So the structure of this panel is as follows. I will introduce the topic and our study, and then I will pose two questions to our panelists. First, I will ask about their experience of patient participation at the organisational level, researching it as a patient group involved in a committee, as an HTA body involving patients via a committee, and as a patient group involved in a non-committee process. Then I will ask for their thoughts on this concept. And I encourage you to ask your questions and share your thoughts on this topic in the Q&A box throughout the session so that we can spend some time discussing them at the end. So this is the question we've been considering. What is patient participation at the organisational level? And a warning, we're not concerned with involvement in individual HTAs here. Our concept comes from the work of Gouvin et al., who a decade ago described the different domains of involvement when conceptualizing public. Note the broader term here, public involvement in HTA following an exploratory study. They recognized that HTA agencies were boundary organizations. That is, they bridged research and policy making and therefore they suggested that involvement must be understood in ways that meet rigorous scientific standards and policy-making concerns. They hoped the conceptual tool they developed would help to bring assumptions and expectations about public involvement into the open, develop common understandings, meaningful practice. So they described 3 domains: policy making, organizational, and research. The organizational domain was defined as processes and procedures that affect the way the HTA agencies are directed, administered, and controlled. In the mosaic of involvement they created, they described it further. You can see there that research activities, for example, are really those we associate with individual HTAs. But in the organizational domain, we're thinking about governing the agency, submitting assessment requests, prioritizing requests, commissioning research, framing technology issues to address, as well as later publishing final reports, making recommendations, publishing recommendations. While Gouvain et al. Considered the domains in a mosaic of levels of involvement, in 2017, Karen Vasey adapted that mosaic further, drawing on later work of Gouvain et al., Otak and Gagnon to view involvement from the perspective of goals. She connected the organizational domain involvement to HTAI's values for patient involvement in HTA: relevance, fairness, legitimacy, and importantly, capacity building as well. The literature suggests that patient involvement in individual HTAs has a role in addressing gaps and uncertainties. It has taken time and study to gain some clarity about this role. But what is the value of organizational domain participation? Does it play a role in achieving goals such as legitimacy, relevance, credibility, feeling included, empowered, and trust? If who we involve in individual HTAs influences how we value an individual health technology, the questions we ask, the evidence we consider, the value we determine, what happens when different perspectives are introduced to the organizational domain? Our project aims to learn more about this less studied area of involvement. With an improved understanding of the actual and possible role of interaction between patient and HTA bodies beyond individual HTAs, we hope to share good practice and potentially create tools to support its wider implementation. So you can see on this slide our study team, which is Hervé, as well as Isabelle Ganache from INESH, and Jean-Claude Dupont and myself. You can see the current countries that we've been studying or are studying. KCE in Belgium, Cardiff took part in the trial, INESH in Quebec, Scottish Medicines Consortium, Health Technology Wales, and HAS in France. And our method was a joint interview to describe the patient or citizen or representative group participation at the organizational level in the agency or country. And then a separate expression of opinion about this participation. So this could be a written or verbal response to further questions. And we hope to write up our results before the end of this year. So this slide helps you, we hope perhaps, to understand the way we are conceptualizing patient involvement at the organizational level. We can see it may be in areas such as management and capacities, such as reinforcing capacities, developing patients' involvement processes, developing process methodologies and governing the agency. And those areas in the operational level marked in the red boxes are also examples of patient participation at the organisational level. And so now I would like to welcome Hervé to share his experiences investigating this topic.
Thank you, Anne. So I am going to speak about Belgium, CACI, the example of patient participation in Belgium. CACI people and patients were interviewed in this study, people study, and we here extracted some elements. For example, concerning the box at the top right, governing the agency, there are patient representatives in the board of CACI. Concerning reinforcing capacity and developing processes and methodologies, there was not a lot of collaborations between the agency and patients. And concerning the box in green, developing patient involvement processes, there was a big initiative for the past 3 years, and I am going to shortly describe it, and also a pilot project with a patient group linked to that initiative. Next, please. So you can see here a paper which was written in 2019, and the objective of this position paper is to address a number of fundamental questions. What is CACI's perspective on patient involvement in policy research and HTA? Does CACI support patient involvement? Why? To what extent? It was the first very important document. Next, please. 2 years later, in 2021, the concrete steps to bring the previous recommendations into practice had to be developed. So a CACI process note with practical guidance for patient involvement in health policy research and HTA was then needed. This process note covers several aspects, such as what are the prerequisites to involve patients, who to involve, how to select the patient or patient representatives to be involved, and which methods to use to guarantee meaningful patient involvement. Next, please. So, what was the patient involvement in this report? Concerning the first report, that is to say the CACI's position concerning patient involvement in health policy research, the board and patient groups were okay to let CACI define its principles internally. And concerning the second report, the practical guidance for PI, there were workshops with patient groups and patients. So in the first one, the involvement was quite limited, and in the second one, the engagement of patients was much larger. How can we explain that? A first reason is obviously the fact that in the second report, CACI wanted concretely to establish working methods. It had to do that with people it was about to work with. And a second reason is that in the first report, CACI wanted to build an internal consensus. Based on a survey amongst CACI employees, the project leaders found that patients have already sometimes been involved in former CACI projects. This position paper was aiming to define a patient involvement policy that was supported by the entire organization. Next one, please. Now, if we have a look to the concrete procedures CACI and patients have defined, we can read that in order to ensure that patient involvement makes sense to the research and to the patients, once a year, after the validation of the yearly research program by the board, CACI will organize a meeting with the umbrella organizations of patient association and the sickness funds. The umbrella organizations receive a 2-page summary of each new project on the annual research program in advance of the meeting to allow them to prepare the meeting with their organization. the content of the documents and the discussion remains strictly confidential. And I think here we are at the heart of patient involvement in the organization of HTA, because patient representatives are going to be able to express themselves about the appropriateness of patient involvement in a given project, and they will give some guidance for that. We also see the articulation between management level and operational level. At the management level, KCE and patient representatives define the general rule for patient involvement, and at the operational level, once a year, patient representatives will bring their input to contribute to organizing the project. Next slide, please. And in parallel to the elaboration of its process note, CACI decided to pilot test a large engagement of a patient group. The patient group is citoyen in the field of mental health. The project psychosomatic care aims at understanding why the somatic care for the severely mentally ill patient is suboptimal and how this can be improved. One step of this project consists of gathering data from the patients themselves. The patient group citoyen was solicited to help recruiting patients, but he asked for a larger involvement in order to participate in elaboration of the interview guide, patient information materials, and so on. In the people study, when we discuss with the HTA body and the patients, there is a descriptive part and an opinion part. And when I spoke to the patient group citoyen, they detailed the following positive aspects of this collaboration. A more important role than just being heard, interesting collaboration with the umbrella organization of patients and KCU. So there is a new kind of relationship with new players for them. A recognition of our expertise in mental health care and patient involvement at a higher level of healthcare improvement. And if we remember the words written by Anne on a previous slide, we can think that this participation probably increased the feeling of being included, being empowered, and trust between players.
Thank you, Hervé. Now could I ask Daniel Cairns to speak to your experience of patient participation at the organizational level?
Yeah, certainly. Thanks, Anne. Good afternoon. My name is Daniel, and I'm a patient advocacy and policy officer with a patient organisation called Myeloma UK. Today, I'm going to discuss the Scottish Medicines Consortium Public Involvement Network, or PIN Advisory Group. Before I discuss the PIN, I'll tell you a little bit about myeloma, my patient organisation Myeloma UK, and how I became involved in the PIN Advisory Group. Next slide, please, Anne. So myeloma is a blood cancer arising from plasma cells in the bone marrow. At any one time, there are around 24,000 people living with myeloma in the UK. Myeloma mainly affects those who are over the age of 65, however, it has been diagnosed in people much younger. It is an incurable, relapsing and remitting cancer. Treatment generally leads to periods of remission, however, patients inevitably relapse as the myeloma evolves and becomes resistant to treatment. Therefore, access to the most effective treatments with as many mechanisms of action are vital for patients with myeloma. Next slide, please. As an organisation, Myeloma UK puts patient need and experience at the heart of drug appraisals to make sure that patients can access new treatments. In my time at Myeloma UK, I've represented patient views and experience at health technology assessments across both the SMC and NICE. We also work to shape government policy across the 4 UK nations to recognise the need of patients with myeloma and related conditions and create positive change. Part of this influencing includes collaborating with our partners in the third sector and also participating at the organisational level of HTA bodies. Next slide, please. As a nationwide cancer charity, Myeloma UK are members of the Scottish Cancer Coalition, which is a partnership of 32 voluntary organisations dedicated to improving cancer services and outcomes for patients in Scotland. The coalition has several subgroups, including a medicine subgroup. The chair of the medicine subgroup, which is myself, sits as a representative on the SMC PIN Advisory Group. And I've been a member of the Scottish Cancer Coalition for Myeloma UK, and then a member of the PIN Advisory Group for about 20 months. So next slide, please, Anne. So what is the PIN Advisory Group? Have the next slide, please. The Scottish Medicines Consortium Public Involvement Network, or PIN Advisory Group, was established in April 2015 and is made up of patient care groups, SMC public partners, and other key SMC representatives. Members use their knowledge, experience, and direct contact with patients and carers to ensure that the views of patients, carers, and members of the public are captured and used to inform SMC processes. Meetings are held 3 times per year, and in the current climate are held virtually. Patient and carer groups are represented by 3 patient group partner umbrella organisations, including the Scottish Cancer Coalition, the Genetic Alliance UK, who represent people living with rare conditions, and the Alliance, representing patients who are disabled or living with long-term conditions. When the PIN was first established, it was set up with a focus on issues relating to the SMC and patient and public engagement. The PIN Advisory Group ensures that the voice of patients is used in SMC decision-making and provides a forum to support proactive engagement between the SMC and patient and carer groups. Next slide, please. So there are 12 members of the PIN Advisory Group. So there are 3 patient group umbrella organisations who are there to represent patient and carer views. It's important that the patient group partners have a strong knowledge of HTA and have experience of submitting to the SMC HTA process from their own organisational perspective. We're also there to represent patient and carer experience and the insight of their engagement with the HTA processes and access to new medicines. We also report back to our respective coalitions and alliances on any updates from the SMC and seek input from our third sector partners to any decisions made by the PIN. Secondly, there are 3 SMC public partners who are volunteers who work with the SMC. They are full voting members of the SMC committee, and as members of the public, they use their judgment on the value of new medicines to NHS Scotland. Thirdly, 5 PIN members are drawn from SMC staff, including operational staff, the public involvement team, and Health Improvement Scotland. And finally, there is an SMC committee member that is a clinical expert who's also a full voting member of the committee, the SMC committee, sorry. So the chair of the PIN Advisory Group sits on the SMC executive, which provides governance to the SMC, and both the chair and the secretariat are currently SMC staff who feed back the views of the PIN to the SMC executive. Next slide, please, Anne. So since 2015, there have been significant changes to SMC processes, which the PIN Advisory Group have been consulted on, and they include a review of the patient group registration and submission processes. PIN Advisory Group also helps to shape the patient group partner participation at the SMC committee meetings, where patient group submissions are presented fairly and accurately by the SMC, with patient groups providing any points of clarity. One of the first processes the PIN advised on was the early embargoed release of SMC decisions to submitting patient groups. The PIN shaped what this process would look like, how many days advance notice were required, and what kind of confidentiality agreement was needed. This had a great impact on patient groups' ability to communicate decisions to their communities and plan for any service impact. The PIN has also been helping to evaluate the added benefit of patient and clinician engagement meetings to the HTA process. PACE meetings help to capture the added value of new medicines not covered by the base case of the HTA and have become a key part of the SMC process. Also, in the fairly new ultra-orphan pathway for medicines which can treat very rare diseases, the PIN Advisory Group was consulted on how the SMC should validate a medicine as ultra-orphan. The group recommended that the SMC public partner should sit on the validation panel, thus increasing public scrutiny. Further to this, the PIN collaborated with the SMC on the positioning of the PACE through the ultra-orphan process. So once a medicine is validated as ultra-orphan and after initial assessment, it will be made available in the NHS for at least 3 years while information on its effectiveness was gathered. In consultation with the PIN, the PACE meeting to highlight the added benefit not captured by the modelling will be held at the end of that 3-year period. The PIN has also been crucial in developing and reviewing new information processes. For example, the decision explained document has been made more patient and public friendly. Also, the summary of information for submitting patient groups document was created with members of the PIN Advisory Group taking part in the SMC's working group. Finally, the PIN also provided scrutiny to the remobilisation of the SMC when its committee meetings were paused due to the pandemic. The PIN was kept informed in the approach to business remobilisation and how the SMC were prioritising HTA and fast-tracking submissions. The PIN has also been able to feed back good practices from the pandemic, such as virtual meetings, and ask for these platforms to always be an option for patients and patient groups when attending SMC meetings. So that's a few examples of where the PIN has added value to the SMC and influenced its processes. Some of these examples are from before my time in the PIN, but it's clear that the role of the PIN has evolved over time from focusing on patient and carer engagement with the SMC to also looking at how SMC processes can affect access to new medicines. For example, with changes to the made to the ultra orphan pathway. Next slide, please, Anne. So what makes the PIN successful? Well, personally, in my short time as a member of the PIN advisory group, I developed a greater understanding of the whole SMC HTA system, which I would not have from taking part in individual appraisals. The PIN is really effective because to my mind, what makes the PIN group successful is the culture fostered by its participants. In my time on the PIN, the ethos of the meeting is focused on openness, partnership, working, and collaboration. There's an atmosphere where all members feel free to contribute and collaborate on the key points of the agenda, and any decisions are made jointly and reached through consensus. Through its short journey, it's clear that the SMC really value the input of the PIN advisory group members. And essentially, it's about having the right people around the table who have a strong knowledge of HTA, who can see the bigger picture and look at how patient and carer involvement can benefit the whole system. Thank you.
Thank you, Daniel. Elizabeth, could I ask now if you could speak to your experience?
Certainly, and thank you, Anne, for the opportunity to speak about our experiences in terms of contributing to the organizational level at HTAs in the United States. Next slide, please. Great. Well, in case you're not familiar with the National Health Council, we're a membership organization, and we were founded more than 100 years ago by and for patient organizations. And today we're made up of more than 140 national health-related organizations and businesses from across healthcare, and our patient groups set our priorities. So we work very closely with our members, in particular, our patient organizations and partner organizations, to ensure that value assessment or health technology assessment is patient-centered and includes and reflects direct input from patients. So as an umbrella organization, it's our goal to learn from the individual experiences of our members participating in assessments to inform our work at the organizational level. Can go to the next slide, please. And the next slide. Great. So to set the stage, I wanted to just highlight that now I'm talking about the US context, which might be a little bit different than some of the contexts of other countries. In the US, we don't have a national health technology assessment body. We have a number of nonprofit organizations. Many of the folks on the line are probably familiar with the Institute for Clinical and Economic Review. There are others as well, for example, the Innovation and Value Initiative, or IVI. And it's also important to recognize that HTA is conducted by all of our individual health insurers to inform their own reimbursement. So they also have specific committees. And so for this particular presentation, I'll be mostly highlighting our relationships and the work that we've done at the organizational level with the nonprofit organizations like ICER and IVI. Can go to the next slide, please. Great. So here I wanted to highlight one aspect that we focus a lot of our work in as an umbrella organization representing lots and lots of different chronic disease patient advocacy organizations. So as I mentioned, we have our members who are involved in the individual assessments, and we gather them through a group that we have, and this is limited to patient organizations in our membership. That's called our value work group. And so we meet regularly to talk about current or recent experiences that they've had participating or contributing to a value assessment. So we learn about surveys or other data that they might have collected, how they felt that their voices were heard, what impact they thought that they had. And it's really an opportunity for patient groups to learn from one another about tactics and strategies and planning ahead if they're about to participate in a value assessment within the next year or two, or even further down the time horizon. So we take those insights that we learn from the disease-specific organizations, and then we tackle those more at an organizational level. And one example of the way that we do that is by commenting on proposed changes. So here's an example of a comment letter from 2020, which was our comments about proposed changes to the methodology that ICER would use across different assessments. And so that's an opportunity for us to take those individual lessons learned and then roll them up on behalf of our members. And so examples of topics that we addressed in that particular comment letter was the amount of time that patient groups as well as other stakeholders had to provide comments or to look at the evidence or the dossier for that particular assessment. And so, we suggested that the timeline should be a bit longer because they really are very substantial documents. We also provided suggestions about how to document the impact of patient engagement in an individual assessment. Also data sources and methodologies that might be useful. So if folks are interested, I've included the link there, happy to send that as well. But that's just one example of the ways that we work with and contribute our comments to value assessment bodies in the US. Can go to the next slide, please. But then we also do lots of other things in partnership with our value assessment bodies. We have representation on advisory committees, and that goes both ways, where we have representation of the patient community on advisory committees that are organized by ICER, by IVI, and by others. And then we also have representation of the value assessors on our own advisory committees. And here's an example. We have a value classroom, and the purpose of that classroom is to provide background resources for patient groups who are new to value assessment and who are about to participate in a value assessment. And many of the tools reference the HTA IPSIG's work, and it's been adapted in some cases for the US setting. But what's really important here in terms of working together with the HTA bodies or value assessment bodies is that the resources are supposed to be impactful. They're supposed to be getting folks ready to engage with the value assessment bodies. And so we can really only do that if we're working together. So just as an example, one of these, we have the considerations guide for patient organizations, and that's a tool that's intended to help patient groups to develop more actionable comments on a specific assessment. And so of course, we wanted to get feedback from ICER and from IVI about, what's useful, what do you need, what's impactful, and so on and so forth. So we definitely take their suggestions to heart in terms of pulling together these materials to be sure that they're useful and relevant. We also work together to create opportunities for patient engagement. So there's been a lot of new opportunities that have evolved over the years. A number of patient advisory committees have been formed, a number of different resources and ways of also communicating out information that patient groups need to know about value assessment or the ways that they've contributed. We've worked together. We also partner to identify disease-specific patient organizations that can participate and contribute to value assessments or to HTAs. Oftentimes it's challenging to identify, who's sort of the the right patient group to contribute, or who's even the individual staff member within an organization that's the right person to contribute or to make contact regarding an HTA. So that's another role of us as an umbrella organization, is to try to make those connections as best we can. We also do a number of collaborations in terms of methods and also advancing the data landscape. So we've had we worked with one of the HTA bodies, IVI, on a project, and ICER was involved in that as well, on a project related to multi-criteria decision analysis and thinking about how, is that a methodology that could be broadly used in the US? Is it the patient-centered methodology? What makes it that way? And so we've worked together on that, and we have a number of ongoing collaborations. And then also in terms of the data landscape, we know that our patient groups oftentimes are interested in fielding surveys, and we're actually starting a new project to develop a survey template that patient groups can embed within existing registries, or that they can field as individual surveys in order to inform a value assessment. And so again, that's another opportunity for us as an umbrella organization to work directly with the HTA body to develop resources that are relevant broadly across chronic conditions, and also to, in some cases, push the value assessment entity to think more about how are they actually using insights from patients. If perhaps there's relevant data that does exist, perhaps that could be used, even if it's not from a trial. Those types of opportunities. One other last one that I'll highlight is an opportunity that we have that came from ICER, where they have an ICER analytics tool where you can go in and you can modify different inputs and assumptions within models that they created. And it's available for a fee for many for-profit organizations and for others, but through our partnership with ICER, we've been able to make that accessible for free for our patient organizations that are members of the NHC. So lots of opportunities for us to work together kind of broadly across assessments. Okay, next slide. Great, thank you. Looking forward to speaking more in a minute. Here's my email in case you had any questions.
Thank you, Elizabeth. That was a fascinating example of capacity building and patient participation at that level. And I'd now like to welcome Alice Evans, who will give us our final example for the session of patient participation at the organisational level. Welcome, Alice.
Hi, thanks very much, Anne. Hi, everyone. My name is Alice. I'm the Patient and Public Involvement Officer for Health Technology Wales, and I'm just going to touch on some examples of where we have patient participation at the organisational level in our organisation. Next slide, please. So at Health Technology Wales, we currently have patient and public representatives in 3 of our work stream areas. So we do have 2 public and patient representatives on our decision-making panels, so our assessment group panels and our appraisal panel. We have a public partner who's currently working with our audit and impact committee on developing a process for us to audit ourselves and then impact our work and the value of our work. And we also have our Patient and Public Involvement Standing Group, or PPI-SG, and this is the group that I'm going to be focusing on for the rest of my time. Next slide, please. So the PPI Standing Group are a group of 8 independent members in addition to Health Technology Wales staff. And these members have all had a great deal of experience in contributing as patients to HTA and also to independent research, and have worked with patient groups across various health conditions in Wales and in the UK, from things such as research into fall prevention in older people, rare diseases, the Genetic Alliance groups in Wales, and mental health, and so on. And this group is 2 years old now, having met for the first time in the April of 2019, and they've achieved quite a lot of work during this time. And their work involves such things as helping us to design a process for patient engagement into our HTA appraisals, designing all of our tools and documents and reports for that work, and deciding how we approach engagement for our topics and whether topics are appropriate for engagement, and if so, what type of engagement. They've also done a lot of work with us on education and outreach events for patient care groups and for the public on who we are as Health Technology Wales. They also reveal all of our content for our patient involvement work that gets included in our documents and our guidance. And this also involves the production of things like plain language summaries. And they advise us and give us advice as is necessary when things arise. Next slide, please. So the work that this group does for us is quite vast, but what I've done is tried to bring out some highlights of what's been achieved over the last 2 years that hopefully shows how their work has helped contribute to the organisation of what we do here in HTW. And the first of these areas then is in our processes. So Standing Group designed with us a process for undertaking patient and carer and public involvement. And this is everything from the timescales and deadlines that we set ourselves to do this work, to who we collaborate with and how we identify people to collaborate with, the types of engagement that are appropriate when undertaking topics, how we find groups to work with, and how we can include patients, carers, and the publics in our meetings, and so forth. And I think it's important to note at this point that as they developed this process with us, they had direct influence then on our appraisal processes in general. And secondly, they've also helped us with designing our tools and documents for engaging with patient groups. So the Standing Group have collaborated with us on designing all our methodology tools, which include things like our mechanism tool, which is designed to help us identify appropriate types of engagement to undertake for topics, all of our search tools that we use to identify patient care groups that we can speak to, and our search tools for including searching on patient evidence in literature. And in designing all of these things, they've helped us write the entire processes up in our standard operating procedures and our guides as well that we produce for patient groups looking to work with us. And more recently, they've been involved in collaborating with us on our education and outreach events to patient groups and to the public. So they've designed with us a series of informative and interactive webinars hosted virtually, which are aimed at improving the understanding of HTA amongst patient organisation groups and the public. So we explore such things as what is a health technology, who are Health Technology Wales, and how can patients and the public contribute to an appraisal. And they've also helped us to deliver this kind of training on a more bespoke individual level, providing us links and platforms to organisations where we can come and hold these kinds of training and speaking with them, as we've done recently with the Wales Genetic Alliance and with Alzheimer's UK Cymru, as two examples. Next slide, please. I wanted to share some examples of how the Standing Group have influenced processes within Health Technology Wales that were already established before they were created as a group. And the first example of this that I think really shows their influence on how we run things as an organisation is in the running of our appraisal panel meetings. So since we established Standing Group and invited members into our appraisal panel meetings, where we decide and make decisions on guidance that we publish to the public, the format of this meetings changed in accordance with the feedback and advice that these members gave us. And that included such things as introducing protected time for patient involvement conversations at these meetings. So these are now inbuilt into our structures for appraisal panel and all our documents for appraisal panel. They also advised us on structured briefings and presentations for public involvement at these meetings. So whereas beforehand, these were sort of asked of people on the day, we now have a full process in place for providing briefs and presentations for this information to be discussed at panels, and also in supporting patient and public attendance at these meetings. So we now have our appraisal panel meetings are now public meetings that the public can attend. And we now have a process in place for inviting patient organizations, patient carer groups to come to appraisal panel meetings and speak directly to these members as they make these decisions. And another example is in the place of patient evidence in Health Technology Wales reviews. So after we began the process of engaging with patients into appraisals, the question that the standing group were faced with is, what do we do with this patient evidence that we gather? And that was a large and ongoing conversation between standing group and our research team and our directors. And there were many different proposals put forward to what we do with this evidence and how we review and report on it. And it was the standing group's position that it should be included within our evidence appraisal review documents in equal representation alongside our clinical evidence and our economic evidence that they put forward and that they insisted on. And that's the position that we are on today. And I'll just briefly touch on the position of standing group in the future of Health Technology Wales as well. So we've just come out of having a big review done on the organisation in which the standing group's work was very highly praised. And then they worked with us on developing a 5-year strategic plan for the future of Health Technology Wales. And one of the big areas that we're going to be asking them to help us establish and look into with us next is going to be in the evaluation of our patient and public involvement process and how this is going and how well we're doing and where the value in this work really lies. Next slide, please. So that's it really from me. Thank you very much for listening. Here's some information if you want to learn more about us.
Thank you, Alice. And thank you to all our panelists for that really diverse range of examples of patient participation at the organizational level. So the next question I asked our panelists to think about was, what do you think about this concept, patient participation at the organizational level? Is it complex? Is it a useful concept? Is it a clear concept? And I wonder, Hervé, could you respond to this first, please?
Thank you, Anne. Yeah, very, very rich examples, in fact. So I would want to make some little remarks about the words. We speak about organizational level, and it is as if it was clear, as if there was no problem in the world, but perhaps it's more complex, in fact, because in our study, you understood that the term is very general. It also includes here what people can call a policy level. For example, when we speak about membership of the board, it also includes establishing HTA methodologies and organization. Perhaps this is not the same. Also, this word must not be confused with the membership in an entity of the HTA body. And sometimes when people hear organizational participation, they think that being a member of a committee of the HTA body. And the example, for example, which was given by Elizabeth, shows that you can have patient participation at the organizational level outside the HTA body with a collaboration thanks to the presence of some members of the HTA body in the initiatives taken by patient representatives. So all in all, we can ask, is this expression misleading? Are there better terms? Perhaps at the end of our study, we will try to provide semantic clarification. So this is a first reflection. Second reflection about the fact that in the interviews we led, the understanding about the distinctive nature of this participation is not always direct. So people don't always make a distinction in the efforts they do in the field of patient involvement. For example, a patient representative on a committee, he can do some efforts to promote patient involvement in the planning of the study, of the HTA, and also he strives, he makes efforts himself or herself to promote the patient point of view in the particular HTA. And for this person, these are general efforts for patient involvement. There is no efforts at the organizational level and after inside the particular assessment in the mind of these people. You can also take the example of a project manager defining a project and integrating patient involvement, including also a role for patient in the organization of the project. For the project manager, it will be a global project without distinctive labels in this project. So probably it comes from the fact that the concept is quite new and it is less known than patient participation in individual HTAs. Next slide, please. And a last remark, and we saw that in the examples which were given. A first element of analysis we can give is that obviously you can obtain a patient participation at the organizational level very differently. For example, as an HTA body, you can rely a lot on patient representatives who are already partners, because, for example, they are members of committees, or you may want to discuss more with exterior players, patient groups, federation of patient groups, population, or you can rely on mixed methods. And in fact, it depends on a lot of things. For example, it depends of the fact to know if there exists or not a powerful federation of patient groups in a given country. And probably sometimes you can replace the methods, but sometimes not, because they have their proper advantages and their proper legitimacy also. So that's all.
Thank you, Hervé. And we come back to this goal and setting, don't we, too, as we look across these bodies. Daniel, could I ask you to come on and give us your reflections on this concept of patient participation at the organizational level?
Yeah, certainly. I think when trying to answer what do you think of this concept, I was mainly thinking about why do Myeloma UK take part in engaging with HTA bodies on an organisational level. Part of me was thinking, well, for access to new treatments is vital for a cancer like, or an incurable cancer like myeloma, and we want to see a system that can bring as many treatments through as possible. So for us as an organisation engaging with HTA on an organisational level, it's really about creating a sustained engagement out with individual HTA. So in our engagement, we can then understand the system as a whole, and that can create better relationships with other stakeholders, including industry, HTA bodies, decision makers, and also clinicians who are vital to the process. At the end of the day, individual decisions can only be as good as the system that they operate in. And by taking part in the organisational level, you can understand the system issues and which solutions belong to each individual stakeholder. I think in my experience, there's a worry in some places that involving patient organisations in HTA too much can maybe slow the process down. And also the HTA bodies really only rely on patient organisations to provide a lived experience for HTA. But I think that's wrong. I feel strongly that patient organisations in HTA should go beyond just patient involvement. We want to be more involved in shaping the HTA processes and demonstrate the added value of our insight. So Myeloma UK are in a unique situation where we take part in every myeloma appraisal across both the SMC and NICE. And in my short time in the organisation, I've taken part in 14 appraisals across both HTA bodies. So through this sustained involvement, we have a UK-wide understanding of access policy, and we feel that our insight can add value. We see the barriers that consistently come up in individual HTA, and we want to be part of the overall solution. I think HTA bodies should know that patient organisations can bring unique insight to its processes, and we have a desire to roll up our sleeves, collaborate, and make the whole system better. A large part of that is based on trust and relationship building between both the patient groups and the HTA bodies. And to build that trust, patient groups need to know what they're talking about firstly, and HTA bodies need to understand that patient groups can offer more. I think the SMC has been terrific at helping patient groups partners shape processes which affect access to new medicines. And the PIN provides a forum for structured decisions which goes beyond SMC business. I think as a continuous improvement, I think I'd like to see more projects come to the PIN at a more earlier developmental stage to get involved with, and maybe some more interaction with key decision makers. But I think the SMC needs to be commended for showing that trust to patient groups and getting the right people around the table to not only discuss, but collaborating on increasing patient carer engagement and understanding how our insights of SMC processes can affect access to new medicines.
Oh, thank you, Daniel. I was really struck by what you said there about understanding about patient groups' desire to understand that whole system, and the perspectives of other stakeholders in there, and the structured nature of the SMC work. Could I bring Elizabeth in now to reflect on this concept?
Sure, thank you. Well, I echo the sentiments of what we've heard already from my co-panelists. I think this is super important that patient groups are involved at the organizational level. And I think it's also important, from an ethical standpoint, for HTAs to always remember that for patients, this isn't a theoretical exercise or some type of a scientific exercise, but it's something that can have really big impacts on patients' access to care. So it's important that there are opportunities for patient participation, not only at the individual assessment level, but also in terms of creating those opportunities at the assessment level, which is really where the patient participation at the organizational level comes in. And so I'm really happy that the PSIG is tackling this topic. I also think that this is really important for the PSIG to take on, because I think that many of us in the individual countries are really sort of making this up as we go. And I think that we could all benefit from a more structured understanding of what's possible, as well as what resources are needed in order to implement those particular engagement opportunities. And I was really struck yesterday, we had the workshop, the Patient and Citizen Involvement Group workshop, and we were discussing the Statement of Information for Patients, which is essentially a patient-friendly dossier. And one of the PSIG projects has been to develop an international template of that, which is of course based on a work product that was originally developed at the SMC. And I think those types of opportunities for us to learn about what are different organizations doing across all of the different assessments, what are the expectations that exist within the different value assessment or HTA entities, can really help each of us who are operating within our own countries to drive the expectations and also to drive change at an organizational level, to be able to point out that your peer institute in X country is doing this. We'd really like to implement this type of a process for across assessments, I think is really helpful. And then, one other thing that I did want to mention, I think it's come up a little bit in the Q&A and the discussion, is really the impact. I think in some ways it's easier for us to understand what's the impact of the patient engagement at the organizational level, because we can see, was an opportunity that we recommended for patient engagement at X stage implemented, or was a particular survey developed that can be used broadly across assessments. I think what can be more difficult is, of course, understanding, once it gets down to the individual assessments, how did that information that came out of those processes that were established, how was that actually used as part of an individual assessment? And so, oftentimes the impact at that particular level is also very unclear. So those are just some thoughts, and looking forward to further discussion. Thanks.
Thanks, Elizabeth. Really interesting point you just made about impact there. And I can see we've got questions on that, so we'll come back to that one as well. But before we go to this great list of questions I'm just noting here, I wonder, can I ask Alice if you could join us on camera to reflect on the concept of patient participation at the organizational level? Thanks, Alice.
Yes, thanks, Anne. I think I definitely agree with everything that's already been said. And for us as an organisation that's still relatively young, we're only really just beginning to have this conversation around this type of patient participation. So it's something that we're working really closely with our standing group on, in identifying where we're doing this well. So almost without realising that this is what we've been doing, but also where the gaps are and how we can start to address some of these gaps and fill these positions. So I did have 2 reflections from our standing group members to bring to this panel today. The first one was a reflection on how greater participation from patients at the organizational level can be of benefit to patient groups and to the public themselves in the being involved in how this work is done and why decisions are made and for what reason, and being involved in all those conversations can really help improve the understanding for patients and the public in why decisions are what they are. And the other reflection that they had for me on this topic then was for us as a HTA, understanding where our responsibilities are as a publicly funded body in terms of our need to be accountable and transparent with the public, and that participation at this level, on this organizational level, with patients and with the public can really go a long way to helping us meet these goals of being fully transparent with patients and the public of what our work is, and our responsibility to be also accountable to them for our work and what our work says. So those are the 2 reflections I had from our standing group members to bring today. So thank you very much.
Thank you so much, Alice. And that's such an important note to finish on that part of the discussion on, because we know more than ever after the last year how public confidence and transparency, how important these issues are. Can I invite all our panelists now to turn on their cameras? And I've got some wonderful questions here. Just excuse me while I juggle my screens. And the first one is from Susan Miles, who raises the question of impact. And her question says, how can we address the impact of patient and public involvement at the HTAI organisational level? Do colleagues have any experience or examples of the impact influence of PPI at this level? Now, I know, Elizabeth, you started to touch on some of your observations of impact. Do you or does anyone else on the panel have experience around documenting impact in this area?
Yeah, so I can answer and come back in about 6 months with an answer. But you know, it's been part of our strategic plan, my organization's strategic plan over the last years, is to, of course, prepare the patient community to engage effectively as part of value assessment. And so as part of the end of our 3-year phase, we're going to be developing metrics and evaluating how has patient involvement impacted ICER assessments, and how has it impacted assessments at IBI as well. But one great example that's specific to a US context, which I realize is much different from many of the folks on the line, but IBI put out a report, which is a scoping report about providing information about exactly how did they engage patients, and then they provided very transparent and very detailed information about individual inputs into a model. And I thought that was really interesting to see how they took the language from patients and then used that. And one good example was in terms of productivity. What they heard from patients wasn't about productivity; it was about career loss or career oriented. I'm happy to share a link to the report so that you can look at that specifically. But I thought that was a really nice example where you could see exactly how a larger advisory committee comprised of mental health experts, including patient organization staff and individuals, contributed at that particular level.
And before I move on, I noticed that Helen Morris has said, is there any way this impact can be relayed back to patient organisations? That one was directed towards you, Elizabeth.
So how it can be, yeah, certainly. Well, I know, for example, ICER has implemented a, and I'm sure others are doing this as well, as a formal debriefing process following each of the individual assessments. And so again, not at the organizational level, but at the individual assessment level, they are having those conversations. So I would reach out to Yvette Venable at ICER, who I'm sure would be happy to chat about how that process is going. She may be on the she may be participating today.
Thanks, Elizabeth. Alice, has HTW done anything in this area?
So we're just beginning to have this conversation. I think I mentioned it in my presentation with standing groups. One of the next challenges now is about how we evaluate this. So far we've been collecting it informally and sort of feedback from groups that we've worked with, where they've provided a sort of written or email feedback. And we do have a process where we always feedback at the end of an engagement with the group. And we've recently started to move that into new realms. So where we've been participating with patients and having formal sort of debriefing sessions with them and going back and sort of presenting to these groups how this work was used. And what the effect and the influence of that has been. And usually they've seen it all because they're involved in this process with us from beginning to end. So they can see how it works out, especially if they attend meetings as patient groups and see that the influence that has been. But we're now going to start holding these sessions where we go back and sit down and debrief the whole thing with the patient organisation group. And we are looking at a way of evaluating all of our work in general. So we'd be looking to learn a lot of lessons from our colleagues and our researchers when they look to form maps for evaluation for our work overall, and including into that our PPI work.
Thank you, Alice. There's a follow-up question for you. So Helen Crosby says, it sounds like PPISG cover a lot of work. How often do they meet and how long for, and are they paid expenses?
Yes, they are paid an honorarium and expenses, and they meet 4 times a year for a proper full meeting, but we meet virtually and correspond in between these 4 meetings every year as well. So they'll review work for us via email or through smaller meetings, as well as these large 4 sort of 3-hour-long meetings that are held every year. Was that all the points I addressed there in that question? 4 times a year, yeah. And then in between each of these 4 meetings, and yes, they are paid an honorarium and expenses.
Thanks, Alice. And I'm just reading Heidi's question here. Following on from questions from Susan and Ken, and I apologise I haven't found Ken's yet, but I'll find it, Ken. I too would be interested in what experience or ideas you have about capturing impact. At NICE, we very recently have approval for a new VCS organisations engagement forum run from within NICE. We are now working to develop information on this, including a web page, terms of reference and sign-up mechanism. We hope to hold the first meeting in autumn. So as you can imagine, if we could put in impact measures or indicators from the beginning, that would be great. So who feels brave enough to tackle that question?
I'll try
Daniel,
that one. I'll try that one, yes. Well, from my straight off back, I think from my experience with the SMC PN advisory group, there isn't sort of impact measurements from how the PIN is impacting on SMC processes or increasing patient and public engagement. I think that's can be seen across the development of the PIN over the 5 years. It's gone from looking at, you know, before my time, but from speaking to people on the PIN at the time, it's gone from looking at just looking at patient and public engagement, then, you know, looking at more sort of processes involved in the SMC. And I think looking at how it's developed shows how much impact it is gaining and the reputation that it's gaining inside the SMC. In terms of actual sort of specific impact measurements, I'm afraid I do not have a full answer for that one.
I'm happy to speak about, I don't think that this is exactly what you'll be looking for, but we have published a rubric about patient centricity and value assessment. And so it provides different domains that would be associated with patient-centered HTA, and then provides examples of what good would look like and then what not so good looks like. And so it might be a starting point for at least, putting together a table of what that could look like, and maybe some guiding language as well. So I'm happy to drop that in the discussion section as well.
Thank you, Elizabeth. I realized I missed one of the earlier questions, and I know we're in our last 5 minutes. Angel said, do you think we should move away from using language such as patient? And if so, how? I wonder, Hervé, can I start with you on that? Because we've grappled with this word patient and the variety of patients in this study, haven't we? Oh, you're on mute. Sorry, Hervé.
Yeah, depending on the processes, sometimes we have to speak about patients. Sometimes this is patient representative. Sometimes this is in Europe, for example, some countries like Belgium or France speak about users, usagers in French, and you have different terms which can be important to considering what exactly you point. But just to come back to the question of impact, we didn't think a lot about that. I'm not sure the term impact is the best one for this this topic, but at least what is interesting is that the fact that I think there is a link with the structuration of this kind of participation, because there are a lot of meetings if you put a structure in place. And so patients are going to see in the next meeting if what they said previously was put in place. And also if there are patient representatives, because, for example, they belong to a federation of patients, the feedback towards their members will be quite easy, because as a member of a federation, just after the meeting, they can speak with their colleagues in different patient group. So the question of feedback, I think, is very linked to the structuration of this kind of participation. And perhaps we will have to think more about this question of impact and feedback. Yeah.
Yeah, thank you, Hervé. And I think that speaks also to Ken's comment there, where he says, if we cannot assess impact well, can we assess quality and appropriateness of PPI at this level? And that's perhaps where we're thinking here. Did anyone else want to make a comment on this word patient? I know I live in the land of health consumers, yet I work for Patient Voice Initiative. So it's a complicated terrain.
I think in some cases we're kind of limited by what legislation says in terms of the terminology that we use. So for example, in the US, we have the Patient-Centered Outcomes Research Institute. And so, of course, they are using the term patient. We have patient-focused drug development. And so there's also those types of considerations as well.
Thank you, Elizabeth. Oh, sorry, Hervé. You have 1 minute.
Yeah, it also depends on the structuration which exists in a given country, because you have some federation of patients. Sometimes it is another kind of federation. And if you speak about representation, all these kind of representatives must be present. So it is strictly linked to the history of different countries also.
Thank you. And I'm sorry to end our Q&A at that point, but I'm very conscious that if we run over time, we just get cut off. And in PCIG, we often get quite enthusiastic about things and run over time. So I'm quite conscious of that today. There is just a wealth of information which has come in the discussion section. So I just need to find out how we access that after our panel, Hervé, because I think it will be so instructive as we take forward our final months on this study. But can I thank our panelists, Alice Evans, David Cairns, Elizabeth Orlean, and Hervé Navarrete for what I think has been a really interesting session about participation at the organizational level. There is a lot happening within these groups and a lot for us to learn from. And so we've really appreciated also seeing the insights in the discussion group throughout this session. And before we finish, can I thank Amran from HTAI Secretariat for being such an excellent host to us today. So thanks very much, and please reach out if you have further thoughts on this.